Your doctor hands you a consent form, a surgery scheduled for next Tuesday, and you sign it because you trust them. But what if, for certain people, at a certain age, some of the most common surgeries in the world carry risks so serious that the surgery itself becomes more dangerous than the condition it's treating? After 60, your body plays by completely different rules, and most people don't find that out until it's too late. I want to be clear before we begin. This video is not about scaring you away from medical care. It's about something more important than that. It's about informed consent, which, according to medical ethicists, millions of older adults are quietly not receiving before they're wheeled into an operating room. A landmark study published in the Journal of the American Geriatric Society found that nearly 1 in 3 surgical patients over 65 experience serious post-operative complications that their doctors never adequately warned them about beforehand. 1 in 3. That's not a rare statistic. That's someone's parent, someone's spouse, maybe, one day, you. So today, we're going to talk about 5 categories of surgery that some of the world's most respected geriatric surgeons and anesthesiologists now openly question for patients over 60, depending on your specific health picture. Stay with me through all 5, because the 5th one is the one most people have already agreed to without a second thought. Surgery number 1, elective spinal surgery for back pain. Picture this. You've been waking up every morning for 2 years with a deep, grinding ache in your lower back. Some mornings, just sitting up feels like climbing a mountain. Your doctor orders an MRI. The report comes back with words like spinal stenosis or herniated disc or degenerative disc disease. And then comes the recommendation, surgery, a spinal fusion, a laminectomy, something that sounds like it will finally fix the pain. Here's what most people never realize in that moment. The MRI doesn't show pain, it shows anatomy. And here's the unsettling truth that many orthopedic surgeons will quietly acknowledge among themselves. Studies consistently show that for chronic back pain in adults over 60, spinal surgery often produces outcomes no better than physical therapy, and in some patients, outcomes that are significantly worse. A major study from the New England Journal of Medicine found that patients with spinal stenosis who chose physical therapy had nearly identical pain scores 2 years later compared to those who had surgery, but without the surgical risks. And what are those risks after 60? After 60, the body's ability to heal bone and nerve tissue slows significantly. Anesthesia, which we'll talk more about later, carries its own heavy burden. And spinal surgeries, when they go wrong in older adults, can leave patients with more pain, nerve damage, or even partial paralysis. There's a reason some of the most respected spine specialists in the world now call spinal fusion for lower back pain one of the most overperformed surgeries in modern medicine. This doesn't mean you should suffer in silence. It means, before you agree, ask your surgeon what your outcomes look like without surgery. Ask for the honest comparison. Ask what 6 months of guided physical therapy and pain management might do first. Your spine deserves a fair trial before it faces a blade. But spinal surgery, as serious as it is not the most emotionally difficult one on this list. That comes later. When a doctor tells you something is wrong with your heart, the fear is immediate and total. The heart. The organ that has been quietly working for you for 6 decades without a single day off. And when a cardiologist suggests a procedure, a stent placement, a valve repair, sometimes even bypass surgery, most patients say yes almost instinctively, because who says no to fixing their heart? But here's where things become genuinely complicated. There is a growing and serious debate within cardiology, not fringe medicine, but mainstream academic cardiology, about whether stenting for stable coronary artery disease actually extends life or reduces heart attacks in patients who are otherwise managing well on medication. The COURAGE trial, the ischemia trial. These are not small studies. These are massive, multi-year investigations involving thousands of patients. And their findings were striking. For patients with stable heart disease, meaning no active heart attack, no acute emergency, Optimal medical therapy alone performed as well as stenting for reducing heart attacks and death. Let me say that again differently. For stable heart disease, the pills, when properly managed, may protect you just as effectively as opening your chest or threading a catheter into your arteries. Now, acute situations are different. A heart attack in progress? An unstable emergency? Intervention saves lives. Absolutely. But elective cardiac procedures for stable conditions in patients over 60 deserve a second opinion. A careful, unhurried second opinion from a cardiologist who has no financial or institutional pressure to operate. Because the risks of cardiac procedures after 60, kidney strain from contrast dye, bleeding complications, stroke risk during certain procedures, anesthesia effects, are not trivial. Your heart is worth protecting. That sometimes means protecting it from unnecessary intervention. Have you or someone you love ever felt pressured to agree to a cardiac procedure quickly? Tell me in the comments. You might help someone else reading them. She's 63, active her whole life, raised 3 children, walked her dog every morning without fail for 15 years, and then her knee started failing her. First, it was the stairs, then the morning walks, then even standing in her kitchen for dinner felt like a test of endurance she was slowly losing. Her orthopedic surgeon reviewed her x-rays and said 6 words that felt like both a relief and a sentence. "I think it's time for replacement." And she agreed, because the pain had already stolen too much from her life. This is one of the most common stories in the world. Knee replacement surgery is performed over 700,000 times per year in the United States alone. For many people, perhaps most, it genuinely transforms quality of life. I want to be honest about that. But here's what nobody talks about before the consent form is signed. Roughly 20% of patients who undergo total knee replacement report that they are unsatisfied with the outcome. Some experience persistent pain, some experience reduced range of motion, some find that the artificial joint doesn't feel right, ever. And for patients over 60, the post-surgical recovery is longer, more physically demanding, and carries a higher risk of complications, including blood clots, infection in the prosthetic joint, which can be catastrophic, and a more difficult rehabilitation process. The question that deserves more airtime than it gets: have you genuinely exhausted the alternatives? Because in recent years, treatments like viscosupplementation injections, platelet-rich plasma therapy, targeted physical therapy, and even new bracing technologies have helped a meaningful number of patients delay or avoid knee replacement entirely, with good quality of life. Nobody is saying suffer. We're saying, before permanent, irreversible surgery, make sure you've given the non-surgical path a real, committed, guided attempt. Your legs carried you this far. Give them every chance before rewriting them in metal and plastic. I want to pause here for a moment, because I realize that for some of you, this video isn't abstract. You're watching this because you have a surgery scheduled, or someone you love does, and you're feeling that specific quiet anxiety, the kind that lives in the chest, that wakes you up at 3 a.m. with questions you don't know how to ask your doctor. I want you to know that feeling is not weakness. It's wisdom. Your instinct to understand before you consent is one of the most important things you can do for your health at any age, but especially after 60. Keep watching, because the next 2 surgeries on this list are the ones that have the most complex emotional weight attached to them. And the 5th one changes how most people think about aging and medicine entirely. This one is the hardest to talk about, because the word cancer triggers something deep and primal in every human being. And when a doctor says that word, the instinct is to fight, to remove, to cut it out and be done with it. But here is a medical reality that oncologists and geriatric specialists are increasingly grappling with publicly. Not all cancers need aggressive surgery, especially in patients over 70 or 75, and especially for cancers that are slow-growing. Prostate cancer is the clearest example. A large percentage of prostate cancers in older men are what oncologists classify as low-grade, meaning they grow so slowly that, statistically, Many men will die with prostate cancer from something completely unrelated, never having suffered meaningfully from the cancer itself. Yet surgery for prostate cancer, radical prostatectomy, carries significant risks of urinary incontinence, erectile dysfunction, and surgical complications that can permanently diminish quality of life. The medical term for this is overtreatment, and it is one of the most quietly painful crises in modern oncology. Several forms of thyroid cancer, certain early breast cancers, and some other malignancies carry similar discussions among specialists. The principle now gaining serious traction in top cancer centers worldwide is called active surveillance, meaning careful, monitored watchfulness rather than immediate aggressive surgery. For many patients, this approach preserves quality of life without meaningfully increasing risk, but it requires something that modern medicine often doesn't give patients enough of: time, conversation, a second opinion from a specialist in geriatric oncology, and the courage to ask, what happens if we watch and wait? That question is not giving up. That question might be the bravest thing you ever ask in a medical office. And now, surgery number 5, the one most commonly overlooked, the invisible risk that follows every single surgery on this list. Here's what most people never realize about surgery after 60. The surgery itself, the cutting, the repairing, the replacing, is only part of what your body goes through. The other part is anesthesia. And after 60, general anesthesia carries a risk that very few surgeons or even anesthesiologists explain with the honesty it deserves. It's called post-operative cognitive dysfunction, POCD, and it is far more common than most patients are ever told. Studies suggest that up to 40% of patients over 60 experience measurable cognitive decline after major surgery under general anesthesia. For most, it's temporary: brain fog, memory lapses, confusion that resolves over weeks or months. But for a significant percentage, particularly patients over 70, or those with early undiagnosed cognitive vulnerability, the cognitive decline can be lasting. There are families, real families, where a sharp, vibrant grandmother went into a routine hip surgery and came out quieter, more confused, less herself, and her family was never warned that was possible. This is not meant to terrify you. It's meant to equip you, because there is a growing movement among anesthesiologists and geriatric medicine specialists toward regional anesthesia, nerve blocks, spinal anesthesia, for procedures where it's possible, which carries significantly lower cognitive risk. It's meant to remind you that before any major elective surgery, not just the ones on this list, the most important questions you can ask are: do I truly need this surgery right now? What are the realistic risks for someone my age, with my specific health history? Is there a less invasive or anesthesia-sparing option? Can I speak with a geriatric specialist before I decide? These are not difficult questions, but they are questions that, for too many people, never get asked. Here's the truth I want to leave you with. Modern medicine is extraordinary. It has given humanity decades of extra life, relief from suffering, and genuine miracles that our grandparents could not have imagined. But medicine is also a human institution, practiced by human beings, operating inside a human system, with pressures, incentives, time constraints, and blind spots. And you, the person sitting in that examination room, are the only one with the full picture of your life, your values, what quality of life means to you, what risks feel acceptable and what risks do not. After 60, your body has earned a kind of wisdom. It heals differently. It responds differently. It prioritizes differently. That's not weakness. That's biology. And it deserves to be honored, not rushed past in a 12-minute clinical appointment. The patients who fare best after 60 are not the ones who blindly comply, and they're not the ones who refuse all medical care out of fear. They are the ones who engage, who ask questions, who seek second opinions without guilt, who understand that informed consent means actually being informed. You are not just a body on a table. You are a person with a history, a family, a future worth protecting. If this video gave you even one question to bring to your next doctor's appointment, It did its job. Share it with someone who has a surgery coming up, because the conversation that matters most is the one that happens before they sign. Before you go, I'd genuinely love to hear from you. Have you or someone you love ever experienced unexpected complications after surgery? Was there something your doctor didn't explain that you wish you'd known? Tell me in the comments. Your story might be the thing that helps a stranger make a better decision for their own life. And if you're over 60 or love someone who is, share this video. Not out of fear, out of love.